Next we go towards carbon dioxide monitoring. As important it is to determine oxygenation, it is also equally important to determine the carbon dioxide monitoring, because we do encounter a lot of patients with type 2 respiratory failure. In fact, more of type 2 respiratory failure than the type 1 respiratory failure, because we have a lot of COPDs, acute exacerbations, bronchial asthma, pneumonias coming, wherein they first land into type 2 and then go into type 1 failure. So, the carbon dioxide monitoring is conventionally done either through capnography, which is a non-invasive monitoring, or it is done through a blood gas analysis, which is to a certain extent an invasive monitoring, but it gives you a true value of your arterial carbon dioxide. So, the levels of carbon dioxide which you get through the blood gas is called as PaCO2, that is your accurate carbon dioxide levels in your alveoli or arterial blood. But here what you get is called as end-tidal carbon dioxide. So, this is at the end of your expiration, how much amount of carbon dioxide you have been able to trace in your alveoli. So, there is some variation between this, and this variation of 1 to 5 millimeters is considered to be normal. So, the difference between the PaCO2 and the end-tidal carbon dioxide of 1 to 5 is considered to be normal. So, coming to capnography, we measure capnography through two ways. One is mainstream capnography or side stream capnography. This is more of a technical aspect, because how the carbon dioxide is measured in a monitor determines whether it is a side stream or a mainstream capnography. Other than that, it is one of the best monitors, because it not only gives you your ventilation levels, it also determines your perfusion, your adequacy of resuscitation, your metabolism, etc. So, I remembered that in the conventional mode of teaching, we were taught that if you want just one monitor on a patient, the most reliable monitor can be your carbon dioxide or EtCO2 monitor. So, this carbon dioxide monitor is two types: volume capnography, time capnography. So, if the curve is like this is your EtCO2 monitor. So, if it is, this is your carbon dioxide levels, and if it is plotted against your respiratory cycle or time, this is called as a time capnography. But if it is plotted against your expiratory tidal volume versus your PCO2, this is called as volume capnography. So, we will see what is the difference between the time capnography and the volume capnography. In general practice, we often use only the time capnography, wherein your carbon dioxide is plotted against your respiratory cycle and you get your end-tidal carbon dioxide. Okay. But then we also have a volume capnography, which gives us an extra added advantage, which we'll learn in the next slide. So, this is the basic EtCO2 waveform, which has got 4 strokes. It usually begins at the end of your inspiration, okay, because we are going to measure the ventilation level of the patient, or the expiration, we are actually monitoring the expiration of the patient. So, the phase 1 of your EtCO2 is your end inspiration. So, at the end of inspiration, when your inspiration ends, this is your phase 1, and then the phase 2 contributes to your beginning of expiration, where the gases from the dead space, where the gases from your tubings are released. So, this is the beginning of respiration, and the gases from your anatomical dead space as well as from your ET tubings, your circuits, everything is released. Then you come to the phase 3, which is almost the peak of your expiration or your main phase of your expiration, where the gases from your alveoli come out, and that end of this phase 3 is called as the peak of expiration or the end of your expiration, where you actually measure your end-tidal carbon dioxide. Once the phase 3 ends, this phase 0 is known as your end expiration. So, at the end of this phase 0, your end-tidal carbon dioxide falls to almost 0, because again this is the phase where you begin your inspiration.